So, Dr.
Thanks, Yogesh. Thank you for the kind introduction. I have slept only 4 hours. So if I talk something incoherent, please pardon me. So lovely, lovely place, lovely gathering. Thank you all for coming in the morning for this EUS, Asian EUS group, EUS training course. We have been doing these courses with AEG for more than a decade. Don't want, yes, 12 years, and they have been highly successful. And I think Yogesh has started it for last 3-4 years here, and it's a great. The results are very good. We have objective proof to see that these things really work. Now, having said that, I have been training students, as Yogesh mentioned, for quite some time now. Hair has become white almost. And while training, I also learn with them. And I tend to try to understand what is it that they come to me for. And what I have understood, and I have tried to change my training methods based on that. So I do not use the standard format used by the AEG. But there are certain things which I would say that there is, first of all, when you pick up the EUS scope, it looks daunting. Whether it is radial or linear, it is a little stiff compared to your gastroscope, ERCP scope. And we are often told to be very careful of perforation. You will perforate at cricopharynx, you will perforate at D1, D2 junction. So the first part that you actually learn is the endoscopy part. And that is an easiest part for most of us who are doing ERCP. Probably 20-25 scopies, you understand how the echoendoscope moves, and that is actually important, but the easiest learning maneuver for you to be able to pass the echoendoscope till D2 from cricopharynx. That is one. Now, once you have that, then you shift your attention to ultrasound. And there is a complete divergence from endoscopy. So, training methods which emphasize on the role of endoscopy while learning EUS miss the point that once you have done the endoscopy, you are comfortable with the endoscopy of the EUS, you don't need endoscopy. You need ultrasound. So it's a very different modality. And I have realized almost half of my students give up because this transition is not possible for them. You do an endoscopy and all the time your mind is, where is this endoscope? And now that is totally not necessary for us to know where the endoscope is. You have to understand what is the ultrasound image that you are getting, what is the correlation that you are making out of it, and what is the next that you expect. So, for example, if you are in the body of the stomach and you turn clockwise, you expect to see the body of the pancreas. That correlation should be there in your mind once you've done enough EUS. Initially, it is not there, so you may be seeing just some retroperitoneal tissue and you don't know what is going on. Where is the head? Where is the body? Where is the tail? How do you look at the mediastinum? Understanding EUS anatomy is the next big act. So there, please try to forget your endoscope. And that is why I am not a big fan of station approach, because it emphasizes endoscopy, mainly because you find things simple. Put the scope in front of papilla and you will see 1, 2, 3, 4, 5, 6 structures. It is not as easy as that. So understand EUS anatomy. Probably if you are doing regularly, you will need about 100 to 120 cases just to understand EUS anatomy. And then comes the last part, which is most difficult, is to get fantastic windows. You know how the sonologists, abdominologists give you very, very good images of the liver, of the gallbladder, that is because they create very, very nice windows. And our job is a sonologist job here. So a transition from endoscopist to a sonologist is actually mentally is very, very important when we start doing EUS. And it's a challenge. It's a really steep learning curve. And if you don't give up, you start loving it. And once you start loving it, you will really create a lot of new things of your own. So let's start with this very, very simple thing. This is the linear scope. It just looks like an ERCP scope. There are few subtle differences. The top end is exactly like that of an ERCP scope. But if you look at the buttons for the air, water, and suction, they are different. They are different because they do a dual job. There is a provision for putting air, putting water into the lumen or putting water into the balloon. And that you can do by pressing the button half and pressing the button full. So that is the only difference here. Apart from that, you have an elevator. You can see that up, down, right, left. How do you hold it is, I'm giving you a very, very basic thing. So if you guys are doing EUS, I'm sorry, but this is how I start my teachings. So three finger has been taught to us for a very long time. So you put your three fingers there, use your thumb to use your thumb for both up, down, and right and left control, so that you can keep your right hand free. You don't need the right hand for maneuvering the controls, and use your thumb also to lock. So if you put your thumb between right and left and up and down controls, it is locked. You don't need to then lock both the controls. So simple things. How do I run this video? Can you run for me? Very brief video. Yeah, down. So see here. So these are the movements that you do up, down, you know all this. And then how to lock. You use your thumb to lock the controls. Very, very useful, especially if you are having a difficult FNA and you want to keep the scope in position. The right hand is often underestimated. I have seen as I train people, they do not use their right hand very well. So as you are learning, you will realize that just using the left hand is not enough, and your right hand should support the left hand so that both the hands are giving a single synchronistic movement to the scope tip. The scope tip has to move the way you want it to. So it's like you're driving a car. Sometimes, most of the times you will probably do it with one hand, but sometimes, you know, you need both the hands to have a synchronized movement. So the right hand, the function is to support, and not only support. You will see if the right hand is pushed a little inside, you push it in, the image changes. If you push it a little up, the image changes. So minute changes will bring changes in the ultrasound window. So experiment with your right hand. Please play this video. Hold it away from the mouth. See, it is at 25 centimeters now. And don't hold it very tight, except when you want to see the uncinate or when you want to see the tail of the pancreas. So this handling of the shaft of the scope is very, 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 very important. How to go about it. And the third aspect is how do you move your body. So initially when we were learning, we were given that you move from here to here and move from here. So I'm a lazy person and I don't think you need to really move so much. Can you put the video on? You basically move see this. This is enough movement. So you're turning clockwise now, you're turning anti-clockwise. So there is a neutral position and then you turn clockwise, anti-clockwise. So the body need not move too much. So these are the movements that you have to practice initially. Now, once you have understood your echoendoscope and you have started introducing the scope and freely putting it in, Initially, when you learn, you will land mostly in no man's land. And yes, I when I train, um, I don't give too much of theory because I know you guys are very, very intelligent and you will read all the books that are available on EUS before coming to me. And so my job is to tell you how to do it. Um, the interpretation is a lifelong learning process. Even I am learning after so many years. Sometimes you are foxed. So interpretation, you keep learning with some basic ideas. So how we do it so that we are able to succeed in about 90% of our cases should be the aim. And the best way I have found is to forget about the endoscopy part once you are into the esophagus. So you can have beautiful views of esophagus, GE junction. There is no need of endoscopy there. Unfortunately, I don't have the videos now. We have sent this for publication. So you get a beautiful sagittal view of the esophagus, beautiful sagittal view of the GE junction, just like you see in CT scans. And you can pick up lymph nodes around, and then you can look at the stomach, entire stomach, like Rangsan has shown all the submucosal lesions, go till the pylorus, and also see beautifully small lesions in the pylorus. So lumen can be very, very beautifully seen with a linear echo endoscope, provided you are oriented to it. And endoscopy actually inhibits you in trying to do a good ultrasound. Coming to pancreatobiliary system, most of the work that I get in my practice is pancreatobiliary EUS. Vast majority of it. Very few are luminal. And as you go on getting known in your area for doing EUS, your practice changes from purely diagnostic EUS to FNAs, FNBs, and then finally interventions start coming in. So initially it will be a lot of diagnostics, but as people have confidence in you, your intervention work slowly increases. But even at the peak, majority of your work, 95% of your work will be diagnostic or FNA, FNB. So these are the two areas you should spend a lot of time on. And think about it. Create your own methods, like I created my own method. Find out how because it's a very, very interesting, very, very interesting area. And when you start doing things, you will realize that you can probably change it a bit. Do that. When we started doing linear EUS, we were taught as soon as you enter the mediastinum, go till the subcarinal angle. Then, in order to enter the abdomen, you turn clockwise and visualize the aorta. Trace the aorta, and then you will see the celiac axis. Then trace the celiac axis, and you will reach the body of the pancreas. Then trace the body and tail of the pancreas. This is a standard classical method. When you do that, and I did this for many years, I realized that I am dividing what is essentially a continuous anatomy, head, body, and tail, into body and tail. And then head, I am looking from the duodenum. So you are breaking the anatomy into two distinct parts. And in that, in my practice, I missed a few lesions in the neck because you are looking at the body and tail, and then you are going and looking at the head. So the neck area, you will not see. So I thought this is a problem. We need to correct it. Similarly, bile duct. Traditionally, we were taught that bile duct starts seeing from the duodenum, from the papilla. Look, and probably by about mid bile duct, you lose interest. That is what traditionally 20 years back we were taught. Hilum, EUS is not good, useless. Don't do linear EUS for hilum. Again, this was against logic. You don't know why liver was not given importance at that time. People were probably concentrating only on the pancreas and the distal bile duct. Later on, now you know in the literature, EUS of the liver has come up in a very, very, very big way. Endohepatology is a very, very important branch of EUS. Now you're looking at segments of the liver. So now you start at the liver, you look at the hilum, you look at the bile duct, and you continue downwards and look at it till the ampulla. So you have a continuous hepato-pancreato system. That is how it should be. That is how anatomically it is. So hepato-pancreato-biliary. Start from the liver. It's more logical rather than starting from aorta and then turning yourself to look at celiac axis. I don't really now understand why I should do that unless there is a problem and I cannot do normal method of going anteriorly from the liver. So like this, what I'm telling you is think about what you are doing. Use a standard method initially, have 2, 3, 4 options always. So I'm not saying be blind towards X, Y, or Z method. So, and it's a long-term process. The process continues. It is a continuous process, and that is why Professor Dongwon's WISE school is something I love, because it's a process. It's not something which ends in half a day or 1 day or 2 days. It goes on and it takes you through different aims and it tests you at every stage. So that also shows that you are interested as a trainee. And of course, the trainer is very, very, very interested because he is testing you at every stage. So it has to be a process rather than anything else. So,
it's okay. Same in EUS. So.
How you stand in this is my friend Mike Wallace had given me long back. We did modify it, but I haven't got that video. So you start from the T junction. You start from the T junction, and the basic rule is if you are turning your scope anti-clockwise, you are looking at the anterior. What are the anterior structures? In the mediastinum, you have the trachea, you have the heart. Some canals. Come down, you have the liver. Not matter. And then there are some structures which are relatively anterior, relatively posterior. If you turn totally posterior, you will see pancreas. Obviously, pancreas is posterior. End of the pancreas is posterior, but is little anterior compared to the tail. So all these subtle differences you have to understand. So if you are trying to go from the tail of the pancreas to the head of the pancreas, you have to turn it exactly because they will be flat. There is spine, and above spine, then you have the head, and then there is the head. So that subtle difference is in the island. As it starts from the papilla, is relatively posterior. When it enters the hilum, it is relatively anterior. So the movement has to be, if you are at the papilla, you are clockwise. As you are turning up towards the hilum, you have to make an anti-clockwise turn so that you are tracing the bile duct in continuity. If you are coming from above, from hilum, and tracing the bile duct, you will have to keep on turning clockwise because you are slowly, gradually becoming posterior. So anatomical considerations are at the heart of everything. Understand what are you doing with the tip of the scope? What is it showing you? What do you want it to show? Correlations. Correlations are extremely important. Can we see this video? Mostly I'm jabbering along. It has nothing to do with the talk here. So you see here, we are looking at the liver now. Then gallbladder, bile duct, and at the papilla. So this is hepatobiliary system we have seen. Now we are seeing the pancreas, pancreatic head, body, and tail. All this can be done from the stomach in vast majority of cases, except in patients who are very obese. So obese patients, you may not complete it, but otherwise, this is the scheme of the things. you have starting from the liver. Now, we have further modified it and it is in publication. We start from the liver. So we included liver anatomy into the pancreatobiliary anatomy. It becomes a single system. Start from edge of the liver, left lobe of liver, look at segment 2 and segment 3, start coming back. Look at the left portal vein, still start coming back. Look at segment 4B, look at segment 5, segment 8, and then look at the IVC, and then turn your scope clockwise to look at the hilum. So you have seen a lot of left lobe of the liver. You are not missing anything. Complete EUS evaluation. Now, if you read textbooks of 10 years back, this is not there. This is an evolution. And yeah, we really have to thank the Koreans. They have really took hepatic ultrasound EUS to a very different level with contrast EUS and other things. So try to make it a system in your mind and correlation. So how do you identify that what you are seeing is a portal vein, is a bile duct, or is an artery? That is where your ultrasound console comes in use initially. Later on, you won't have these questions. So use Doppler. There are a variety of Dopplers in your machine to check whether it is a venous flow, it is an arterial flow, or no flow. There is no flow, obviously it's a bile duct or a pancreatic duct. Portal vein, hepatic artery will have different kinds of flow. So distinguish it. Initially use Doppler lots, no problems. Later on, you will not need it so much. So this is the schema. See here, begin from the, we have extended it a bit more now. So begin from end of the liver. Start the liver anatomy first, then go to the liver hilum, common bile duct, push down. And all this is probably 7 centimeters. That is another mistake we do when we start learning, because stomach is huge. So you think that you have to go all the way till the antrum? No. In 5, 6 centimeters, 7 centimeters, you finish everything. It's probably 1.5 vertebra or 2 vertebrae at the most, the entire game. And then you turn your scope clockwise and go to body and tail. Video, please. So now you see we are at the hilum. This is a very fast video. We are at the hilum. You are seeing a very thickened bile duct. You are seeing a gallbladder and you are seeing the portal vein. So bile duct is thickened because there has been a stent in it. So you can see this. This is the view just underneath the liver hilum. Subhilar. You can see gallbladder. You can see the liver. So this anatomy you have to orient your mind to. The whole thing is shifted like this. Liver is down, bile duct is going up, and pancreas is there. So that orientation has to come. Now let's trace it. Once we trace the portal vein, we are also seeing the pancreas appearing. So see there, head of the pancreas has appeared. And the portal vein, if you follow it, you see the portal vein divides and then you see the head of the pancreas. Now you see a stent in the bile duct. Gallbladder is still seen. And this is the duodenal bulb. You see this air? This is the air in the duodenal bulb between the gallbladder and the bile duct. So you can see duodenal bulb. You can see this air here. This is the air in D2 and D3. These subtle things, as you start doing it, you will realize that you are seeing wonderful anatomy inside and evaluate practically everything. So now you know the head is here because the portal vein will go like this straight. So this part will be the head and the body and tail will go that direction. So you have to turn like this to look at the body and tail. So this is the confluence of the portal and the splenic and superior mesenteric vein forming the portal vein. We continue the same thing. Can we start the video, please? Now we are tracing it into the head, you see? See this? This is air. Now you are reaching, this is the D2, D3. You see this line? So this defines the head of the pancreas. This is D2, D3, air in the duodenum. So your bile duct has to reach there for you to see that you are completely seeing. Of course, ampulla will be difficult because there is air in the D2, D3. But you can see the entire head beautifully. The C of the duodenum can be seen. You can see the pancreatic duct coming here. See this? Okay, next. I think I have spoken too long. Next. This is CBD, of course. Tumor. Oh, of course. Here, now you see something here. Interesting. Start. Now what you are doing is you're turning clockwise and you see this round duodenum. See this? Underneath is the IVC. So our anatomy tells us that the IVC is directly underneath the head of the pancreas. So this is the head of the pancreas. The aorta is directly underneath the uncinate process of the pancreas. So aorta, IVC, and duodenum. So this is the uncinate. How do you know this is uncinate? You will see the SMA joining the aorta. The angle of the SMA and the aorta, that is the anatomical landmark, and sometimes you will see the left renal vein there. So this is the duodenum here. See this? This is the duodenum. This is the head of the pancreas, and this side will be the uncinate process. See this side. So you will never see a better uncinate process in any other maneuver. This is anatomical description of uncinate process. Okay. Can you start this, please? This is very fast video. So you see here, body of the pancreas, dilated pancreatic duct. Here, see this? I'm turning now clockwise, turning the body clockwise. See, duct is still dilated, left kidney, adrenal, left adrenal, still turning clockwise, and you will see the spleen. So this is the spleen. So sometimes you tend to stop at the aorta. Please don't do that. Continue till you see the spleen, then only you have seen the pancreas completely. This is the kidney, again coming back. So I'm reversing the same move anti-clockwise. Again, we are seeing a dilated duct. I'm tracing the duct anti-clockwise by an anterior movement. You're seeing, see here, this is the pancreatic duct. I'm tracing it. See, now it has come to the head of the pancreas. We are tracing it in the head. It is still dilated. Head. This is the neck. And here is a hugely dilated bile duct and a pancreatic duct. So by now we know already what we are dealing with. You don't need to see a lesion. But of course, there is a lesion here. So all this is done from the stomach. You see, it is blocking the bile duct, also blocking the pancreatic duct. And this, of course, is the duodenum, air in the duodenum. I think I'll stop this. Do I have time or should I stop? Yogesh? 5 minutes? Okay. Scanning from the duodenal bulb. Please start the video. So remember that when you land in the duodenal bulb, your scope is mostly looking posterior. And so you should see the head of the pancreas, the bile duct, and the portal vein. So if you turn anti-clockwise, you will trace towards the liver. If you turn more clockwise, you will trace the head of the pancreas, head and uncinate process. So this is a standard maneuver, nothing much to talk about. Yes, I'll show you one video. Show, please. Hugely dilated bile duct, you can see here. Now, you turn clockwise or anti-clockwise, you will see here, big bile duct and portal vein. You should also see a distended gallbladder here. So this we are turning anti-clockwise. See, because we are seeing the gallbladder and the liver. See cystic duct here, cystic duct. Then turn clockwise again. And you see the pancreatic duct underneath. See this becoming very big. Now we are coming close to the papilla. And still the ducts are dilated. So that means there is a small lesion in the papilla, intraduodenal part of the papilla. So thinking this process lets you think, okay, where is the block? Where should it be? Is it at a hilum? Is it at the pylorus? Various things. Start, please. From D2, what you do is your ERCP maneuver, go beyond the papilla, shorten the scope, and turn anti-clockwise. When you turn anti-clockwise, you will see big vessels, aorta and IVC. Withdraw your scope millimeter by millimeter, and here you may have to use a torque to see the uncinate process. So this is the schema for D2. This looks, I have named it after Z. So you see very contorted. Start from the D2 anti-clockwise movement. You see the aorta, then clockwise and withdrawal. Uncinate, then papilla, and then end. That's it. I think that should be enough.
Thank you very much. Thank you. Very lucid and clear presentation, sir.
Thank you. Thank you.
It will really help the beginners. And any questions for Dr. Dhir? Practical questions.
I gave a good lecture. No questions.
No, I want to ask.
Yeah.
Sir, that sometimes we really struggle to see the uncinate. No, it's a difficult area to image, and the scope keeps on falling back from the duodenum into the stomach.
So uncinate, I have seen with my trainees, they are scared. And that is why they don't see the uncinate. They are scared of two things. One is at the back of their mind, the scope is always falling back into the pylorus. So they don't do enough movements. Second is they do not torque their scope enough. So if you do not torque your scope enough, you will not see the uncinate. So mostly it is a state of mind. It's nothing else. So if you are not worried about, and you will not be worried once you are confident that my scope, even if it comes out, you can put it back again. There is no problem. It hardly takes 30 more seconds. So don't be afraid of that. And you need more torque than what I have seen most of the people giving for uncinate process. And when you do that, you miss the ducts because you are concentrating on uncinate process. So when you come back and try to look at the pancreatic duct and bile duct, you have to again turn a little bit anti-clockwise to see the ducts properly.
Sir, what's the trick for the low CBD and ampullary region? Because from D1 we can really see the mid CBD and the lower CBD very well, and sometimes from the ampulla it's not very easy to miss it.
Yes,
so that area is a blind.
So small ampullary lesions are a challenge, and prior to ampulectomy you should do EUS. So keep your tip a little above the ampulla, fill the duodenum with water, if required give Buscopan, and spend time. Look at each layer of the duodenum, what is happening in the papilla. You should be able to see the entire papilla well. And if the duodenum is contracting too much, you will not see it. So give Buscopan. And you should be able to see it pretty easily.
Okay. Any? Yeah.
Thank you very much for this nice lecture and hands-on training as well. Just I wonder, sometimes when I examine pancreas, just below gastroesophageal junction, sometimes I prefer, if I want to see tail of pancreas, sometimes I can't see it from clockwise. When I go anti-clockwise, I can see it properly and perfectly. And even I found 2 times cyst in tail of pancreas through anti-clockwise, not clockwise. So do you agree? And what is the explanation?
Yeah, I think there is a very, very easy explanation for this. So when you say clockwise or anti-clockwise, we are just talking about 180 degrees from here to here. But if you turn too much, then your clockwise becomes anti-clockwise. You understand? It's basically a clock, at which you are looking. So if you're turning too much, you are again looking at it as if you are doing clockwise. And so you feel that why you are not seeing it in clockwise movement is fundus has air. Sometimes you push your scope too much and compress the pancreas. So all you are seeing is the retroperitoneal connective tissue. What I suggest you do is do a normal clockwise and put some water in the fundus if you're not seeing the tail. And try to separate your tip from the stomach wall. So go to the aorta, go more clockwise. Don't stop there. Once you've seen the aorta, it's not the end of the story. Go more clockwise. So that is too much clockwise. Put some water if you're not seeing. Very rarely it is required. And use your up-down control so that this tip is lifted away from the stomach wall. You will see the tail beautifully. But if you are seeing it with this also, there is absolutely no problem. I think that's fantastic. No issues. Yeah.
If I add one more comment on that, stomach, especially the fundus, is spacious. So when you do clockwise or anti-clockwise rotation, you need to keep the pancreas in 6 o'clock position. If you lose the pancreas, your axis is not rotating alongside of the long axis of the pancreas. We are talking about, this is long pancreas, then we are talking about changing like this. But sometimes your axis can be like this, and it can go different directions. So should keep the pancreas in a 6 o'clock position, then try to rotate. If the pancreas tissue is getting away from 6 o'clock position, then you are turning into the different angle. Yeah.
Absolutely, absolutely.